Welcome to Prism Rounds, the audio journal club where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. A quick note before we start, this episode is created using AI-generated voices. I originally made these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. Because the voices are synthetic, you may occasionally hear mispronunciations of medical terms, drug names, or author names. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. Let's get into today's paper.
Hello and welcome back to the deep dive. Before we begin our analysis today, just a standard disclaimer.
Right. This deep dive is for educational and informational purposes only.
Exactly. It does not constitute medical advice. Please, consult your local protocols and use your clinical judgment.
We're here to dissect the evidence, not to write the orders for you.
So today we are setting the frame around a very specific, very high-stress scenario. We are talking about severe metabolic acidemia combined with KDIGO stage 2 or 3 acute kidney injury.
Moderate to severe AKI.
Right. And the core question we are looking at is that tension, the tension between a true mortality benefit versus just, shifting your dialysis decisions.
And we're doing that by looking primarily at the BICARICU-2 randomized clinical trial,
which was published in JAMA in 2025.
Along with its editorial, and of course, we have to talk about the predecessor study, BICAR-ICU from The Lancet in 2018.
We absolutely do. But first, I want to take you to a place that I know every clinician listening has been.
The bedside.
The bedside. It's 4 a.m. on a Monday. It's always a Monday.
It really is. You're standing at the bedside in the ICU. You have the mechanical ventilator whooshing in the background.
Yeah.
The rhythmic beeping of the monitor.
Which is probably the only calm thing in the room right now.
Literally the only calm thing.
Yes.
Because you are looking at a patient who came in 12 hours ago with septic shock.
And they are not doing well.
No. They're maxed on norepinephrine. Vasopressin is already running. You are mentally calculating the dose for a third pressor.
And then the nurse hands you the slip from the blood gas analyzer.
Yeah. And it's that specific shade of bad news. The pH is 7.15.
Oof.
The lactate is climbing. It's past 5. And the bicarbonate is, it's in the single digits.
And you look at the Foley catheter.
Right. The urine output is effectively 0 for the last 4 hours. You are staring down the barrel of severe metabolic acidemia and acute kidney injury.
And in that moment, the tension in the room isn't just about the patient's underlying disease. It's about the decision you have to make right then and there. Exactly. Because the reflex, the absolute overwhelming reflex when you see a pH of 7.15 is to fix the number.
You want to make the gas look pretty.
You really do.
Yeah.
You want to grab that ampule of sodium bicarbonate because it feels like doing something.
But deep down, there's this nagging doubt. Are you actually treating the patient, or are you just treating the paper?
That is exactly the conflict we are dissecting today. We want to know if giving intravenous sodium bicarbonate to these specific patients actually saves lives, or if it just buys time before kidney replacement therapy.
KRT dialysis.
Right. So to answer that, we need to talk about why that pH of 7.15 scares us so much in the first place.
It's not just a number on a scale for you guys at the bedside?
No, not at all. When the pH drops below 7.20, we are literally watching a fundamental breakdown of cellular machinery.
Right. It's about protein folding and receptor sensitivity.
Exactly. Think about the beta-adrenergic receptors on the heart and the vasculature.
These are complex proteins.
Right, and they rely on a very specific three-dimensional shape to function, to catch the catecholamines you're pumping into the IV.
But in a highly acidic environment.
In that acidotic state, those proteins undergo conformational changes. They physically change shape.
So you're pouring in norepinephrine to maintain perfusion pressure, but the lock has changed shape.
The key just doesn't fit anymore. You get this profound catecholamine resistance.
You can double the dose, triple the dose, but the receptors are becoming deaf to the signal.
Yes. And at the exact same time, inside the cardiac myocyte, that excess hydrogen ion concentration is just wreaking havoc.
Because it competes directly with calcium, right?
Exactly. It competes for the binding sites on troponin C. And without calcium binding to troponin,
You don't get the actin-myosin cross-bridging.
you don't get the mechanical squeeze, so cardiac contractility just tanks.
And the systemic arteries dilate because the smooth muscle can't hold tone.
Because of that receptor failure we just talked about. But here is the really cruel twist of physiology.
The pulmonary vasculature.
Right. The pulmonary vasculature does the exact opposite. It constricts in the face of acidosis.
So you have a failing right ventricle trying to push against a clamped-down pulmonary system.
While the systemic pressure is completely collapsing, it is a hemodynamic death spiral.
Which is why clinicians panic at 7.15. That's the nightmare scenario of arrhythmias, pump failure, profound hypotension.
And historically, faced with that Monday morning patient, we had two roads out of this valley.
Road number one being kidney replacement therapy, KRT.
Yes. Dialysis. We put in a massive catheter, hook them up to a machine, and literally filter the acid out of the blood.
It works, but it's a heavy intervention.
It's incredibly invasive, and it is not benign. You are sticking a large bore catheter into the jugular or femoral vein of a patient who might be coagulopathic.
You risk bleeding, infection, thrombosis.
And the initiation of dialysis itself often causes a sudden drop in blood pressure.
Intradialytic hypotension.
Right, which can further injure the kidneys or the heart. Plus, it's heavily resource intensive.
So then you look at road number two, the bicarbonate push.
The perceived easy fix. But you and I both know that sodium bicarbonate isn't just neutralizing juice.
Far from it. And this is where the controversy really lies. When you mix bicarbonate with acid in the blood, you get water and carbon dioxide.
Basic chemistry.
Basic chemistry. But CO2 diffuses across cell membranes instantly.
Much, much faster than bicarbonate ions can follow it.
Exactly. So you might raise the pH in the blood, in the extracellular space, but that surge of CO2 floods the inside of the cells.
Potentially worsening the intracellular acidosis. You are polishing the exterior while the house rots on the inside.
Plus you have the sodium load to worry about.
And the potential for hypocalcemia, which, as we said, further depresses the heart. It's a messy drug.
And the decision to start KRT is messy too.
Very messy. We have criteria, sure, but in the heat of the moment, it feels very subjective. Clinicians often use acidemia as a trigger.
If the pH stays low, you dialyze.
Right. Which brings us to the crux of the problem with these trials. If you give a drug that artificially raises the number...
You are removing the trigger for the procedure.
Exactly. So are you avoiding the procedure because the patient genuinely got better?
Or just because you masked the symptom that normally forces your hand?
That is the million-dollar question.
Yeah.
And to understand why this new study at BICARICU-2 is such a massive deal, we have to rewind to 2018.
The original BICAR-ICU trial.
Right. Published in The Lancet.
They took unselected critically ill patients with severe metabolic acidemia. And overall, the result of that trial was actually negative.
Neutral, yeah.
Right, neutral. Bicarbonate did not reduce the primary composite outcome of mortality and organ failure for the whole group.
But buried in that paper was a subgroup analysis that literally set the critical care world on fire.
The AKI stratum. They had pre-specified a look at patients with significant kidney injury, KDIGO stage 2 and 3.
And in that specific group, the mortality signal flipped completely.
The patients with moderate to severe AKI who got bicarb had a 28-day survival that was dramatically better.
We are talking about a mortality drop from 63% in the control group down to 46% in the bicarb group.
A 17% absolute risk reduction.
In critical care. That is unheard of. We usually pop champagne for a 3% difference.
It was almost too good. And that is the danger of subgroup analyses. Statistically speaking, they are hypothesis generating, not definitive proof.
But clinicians are desperate. We saw that 17% number and said, okay, that is the rule now.
If the creatinine is high and the pH is low, you give the bicarb.
It became the de facto standard of care, based entirely on a subgroup of a negative trial.
Which is very shaky ground to build a widespread protocol on.
Very. So the same research group, to their immense credit, decided to double-check their own work.
They launched BICAR-ICU-2 specifically to see if that lightning would strike twice.
This is what we call a confirmatory focus trial. It targets only that population that seemed to benefit previously.
So let's get into the gears of this new machine. You set the bedside scene perfectly, but I want to look under the hood of the methods.
Lead the way. Let's do a tight journal club on the design.
This was a multi-center, investigator-initiated, open-label, randomized controlled trial.
Multicenter is great. 43 ICUs in France.
Investigator-initiated is also great. No pharma bias.
But open label, that is the one that always makes me raise an eyebrow.
It definitely should. Open label means everyone, the doctors, the nurses, the investigators, knew exactly who was getting the bicarb and who wasn't. There's no placebo.
And that matters tremendously because the endpoints here involve human behavior.
Exactly. One of the main reasons to start dialysis in these patients is a low pH.
Right, so if I know the patient is in the control group and I see their pH is 7.15, I am triggered to start dialysis.
But if you know they are in the bicarb group and the drug pushes their pH up to 7.25...
I might look at that gas and say, oh, they look fine, let's wait on the catheter.
Right. The intervention mechanically removes the trigger for the outcome you are measuring.
It creates a self-fulfilling prophecy regarding dialysis usage.
Precisely. If the protocol rule is dialyze, if pH is low and the drug makes pH high, the drug will always appear to reduce dialysis.
It's baked into the math.
We call this a behavior-sensitive endpoint. It's a huge susceptibility in open-label trials.
Physiology meets protocol. Here we go.
Keeping that massive caveat in mind, let's look at the patient population.
Who actually got into this trial? How do I recognize this patient on my ward?
They were very strict because they wanted to replicate that 2018 subgroup exactly. So, adults admitted to the ICU within 48 hours.
Okay, for admissions.
Enrollment ran from October 2019 through December 2023, with the last follow-up ending on June 17, 2024.
And the specific criteria?
Severe metabolic acidemia, defined as a pH less than or equal to 7.2 arrow.
With a PACO2 less than or equal to 45 millimeters of mercury, right, to rule out respiratory causes.
Correct. And a bicarbonate less than or equal to 20. And crucially, they had to have KDIGO stage 2 or 3 AKI.
Moderate to severe kidney hit. And they needed a severity trigger too, didn't they? Just having a low pH wasn't enough to get randomized.
Right. They needed a total SOFA score greater than or equal to 4, or an arterial lactate greater than or equal to 2 millimoles per liter.
Basically, they needed to be sick, true organ failure, or shock.
Who do they exclude?
Well, respiratory acidosis, obviously. Ketoacidosis, like DKA, because the treatment there is insulin and fluids, not bicarb.
They also excluded chronic kidney disease, stage 4 or 5.
Makes sense. If the kidneys were already gone before they got to the ICU, you weren't in the trial.
And exogenous acid poisonings like aspirin or methanol. Plus anyone with massive bicarbonate loss from the digestive or urinary tract.
Okay, so that's our trial-like patient. Now let's talk about the intervention, the recipe.
If you were randomized to the treatment arm, what did you actually get?
Well, in the U.S., we often just slam these 50-milliliter ampules of 8.4% bicarb. Is that what they used in France?
No, and this is a really key physiological distinction for the protocol. They use 4.2% sodium bicarbonate.
So it's half the concentration of the standard crash cart ampules.
Exactly. It is still hypertonic compared to plasma,
Yeah.
but it's much less concentrated. And they didn't just push it. They infused it in boluses of 125 to 250 milliliters over 30 minutes.
So it is a slower, slightly more dilute load, less risk of that massive, immediate hyperosmolar spike you get with the 8.4% push.
Correct. And they titrated it. It wasn't just a set dose.
The target was to get the arterial pH greater than or equal to 7.30, right?
Yes. They would check a blood gas 1 to 4 hours after the infusion. If you were still below 7.30, you could get more.
But there was a hard cap.
Strictly capped. Maximum 1,000 milliliters within 24 hours. They clearly didn't want to overload these patients with sodium and fluid.
And what about the comparator, the control group?
Standard care. No bicarbonate infusion at all.
But no placebo, as we established.
Right. And importantly, because it was open label, if a patient in the control group was deteriorating rapidly, the clinician could cross over and give bicarb as rescue therapy.
But per the strict protocol, they were supposed to get nothing. Now, what were the primary endpoints?
The primary endpoint was hard and objective. 90-day all-cause mortality.
Did they live or die at 3 months?
Exactly. Secondary endpoints included the need for KRT, days free of KRT, and organ failure scores.
Let's circle back to the KRT criteria in the trial. This connects directly to the bias we discussed.
The trial protocol had very specific rules for when to start dialysis.
They had emergency criteria and deferred criteria.
The emergency criteria were things like hyperkalemia with ECG changes or severe pulmonary edema.
Everyone agrees those need dialysis immediately. You don't wait on those.
But then they had deferred criteria, assessed at 24 hours. These were oliguria, a potassium over 6.5, or
pH less than or equal to 7.20. There it is, the acidemia trigger.
By explicitly including a pH of 7.20 as a trigger for dialysis in the protocol, they practically guaranteed a difference in the secondary endpoint.
Because the group receiving the pH-raising drug will hit that trigger far less often.
Exactly. So we have a study designed to confirm a mortality benefit, but with a secondary endpoint that is heavily influenced by the study design itself.
So let's see what the numbers actually showed. We are moving to the results, just the numbers here.
Let's start with the big one, the primary outcome, 90-day all-cause mortality.
I have the numbers right in front of me. In the bicarbonate group, 195 out of 314 patients died.
That is 62.1%.
High mortality. These were incredibly sick patients.
In the control group, 193 out of 313 patients died. That is 61.7%.
62.1% versus 61.7%. The absolute difference is 0.4%.
Which is basically zero. It is just statistical noise.
The confidence interval went from minus 7.2% to plus 8.0%, and the p-value is 0.91.
That is as non-significant as it gets. If you look at the survival curves in the paper, they are practically superimposable.
They lie right on top of each other. So that massive signal from 2018.
The 17% mortality reduction in the AKI subgroup.
Poof. Gone. Vanished. It was not replicated at all.
This trial strongly suggests that in this specific population, bicarbonate has absolutely no effect on whether you live or die at 90 days.
That is incredibly sobering for anyone who has been relying on that 2018 data. But let's look at the key secondary outcome, KRT usage. Did the baked-in bias show up?
Oh, it absolutely did. In the bicarbonate group, 35% of patients received dialysis by day 28.
And in the control group?
50%.
Wow, 35% versus 50%. That is a huge difference, an absolute difference of minus 15.5%.
And it is statistically robust. The confidence interval is minus 23.1 to minus 7.8.
So highly significant. And for those in the bicarbonate group who did eventually get dialysis,
they started much later. The median time to KRT was 31 hours in the bicarb group versus 16 hours in the control group.
So it delayed dialysis significantly, and for a full 15% of patients, it prevented it entirely.
Yes. But again, we have to ask the critical question, was that because their kidneys actually recovered faster?
Or just because their pH was 7.25 instead of 7.19, so the doctors didn't pull the protocol trigger?
We will debate that interpretation in just a moment. What about the subgroups and sensitivity analyses?
The PERP protocol analysis, which excluded crossovers, showed similar results.
Right. About 15% of the control group received bicarbonate as rescue therapy.
But even accounting for that, it did not alter the mortality neutrality. What about safety outcomes? We always worry about sodium overload and alkalosis with these drips.
Those things definitely happen. Metabolic alkalosis, hypernatremia, and hypocalcemia were all more common in the bicarbonate group.
But the paper reports no life-threatening complications directly attributed to these shifts. They were manageable.
There was one unexpected finding, though, that I found really fascinating.
The infections.
Yes. ICU-acquired bloodstream infections were significantly lower in the bicarbonate group, 4% versus 9%.
That is wild, right? Bicarb isn't an antibiotic. What is the mechanism there?
It is almost certainly the dialysis catheters.
Oh, of course. If you have 15% fewer patients getting dialysis, that is 15% fewer patients getting a giant central line placed in a major vessel.
Fewer invasive lines means fewer entry points for hospital-acquired bacteria.
So it's an indirect benefit. You avoid the procedure, you avoid the complication of the procedure.
Exactly. It brings us back to the idea that doing less might actually be doing more, at least safety-wise.
So let's move into interpretation. How do we make sense of this? We have a drug that fixes the number on the blood gas, it spares the dialysis machine, it cuts the bloodstream infections.
But it doesn't save the life.
Right. Let's talk about that mortality neutrality first.
The editorial in JAMA makes a really important point here about the framing of uncertainty.
Editorial framing of uncertainty sounds like a statistics burn.
It is a general reminder to look closely at the confidence interval. The interval was minus 7.2 to plus 8.0.
Meaning the true effect could lie anywhere in there.
Right. The data is statistically compatible with up to a 7% absolute benefit or up to an 8% absolute harm.
It is not definitive proof of zero effect.
No, but it is absolute proof that the massive 17% effect we saw in 2018 is extremely unlikely to be true. Compared to that dramatic signal, this is effectively a neutral result.
Clinically, for me at the bedside, this tells me bicarb is not a magic bullet for survival in AKI and acidosis. It doesn't fix the underlying problem. It doesn't fix the sepsis or the shock.
Exactly. It treats the symptom, the acidemia, not the disease driving the organ failure.
Now, what about the KRT reduction, real or artifact? We talked about the bias of the open label design and the pH triggers.
It's almost certainly a mix of both. Yes, the protocol forced a difference. By fixing the pH, you eliminate the acidemia trigger.
But does it matter why you avoided dialysis if you successfully avoided it? That is the clinician's argument. Look, dialysis is risky. It causes bleeding, hypotension, infection.
Avoiding dialysis is a clinical benefit. If you can give a drug that lets you safely avoid starting a filter, that's a win.
Dialysis saved, but did outcomes move?
The catheter stayed in the box, but the mortality curve stayed flat. That is the headline.
So the synthesis here is that the drug acts as a dialysis-sparing agent, or at least a dialysis-delaying agent.
It allows the kidneys time to recover without needing the bridge of continuous or intermittent KRT.
So what changes Monday? This is what the listeners are waiting for.
Practical application.
I am standing there. The pH is 7.15, the lactate is 5, the creatinine is 3. Do I give the bicarb?
Let's build a simple decision scaffold for the bedside. Step 1. Identify the patient.
They have to match the trial.
Right. pH less than or equal to 7.2 AO plus KDIGO 2 or 3 AKI plus a severity trigger.
Like a high lactate or a SOFA score of 4.
If they match that, they are a candidate. Step 2. The bicarbonate strategy.
If you choose to give it, you should mirror the trial dosing. Don't invent your own protocol.
Dose with the 4.2% hypertonic solution. 125 to 250 milliliter boluses over 30 minutes.
And the target is a pH greater than or equal to 7.30.
Capped at a maximum of 1 liter per day.
And obviously monitor closely. Check the blood gas 1 to 4 hours after the infusion.
Step 3. The KRT parallel plan. This is crucial.
Do not let the bicarb be an excuse to ignore other dialysis triggers.
Exactly. If the patient is fluid overloaded or has refractory hyperkalemia, you initiate KRT.
Temporizing must not become drifting. We can buy time, but if the patient doesn't turn around, or if other criteria are met, we dialyze.
And step 4, managing expectations.
What do you tell the team or the family? You say, we are using this to potentially avoid or delay dialysis.
But there is no evidence it improves 90-day survival.
Right. So let's close this out. The 3 main takeaways.
Takeaway 1, mortality neutral. BICARICU-2 showed no survival benefit for sodium bicarbonate in severe metabolic acidemia with AKI.
Takeaway 2, KRT sparing. Bicarbonate significantly reduced the use of KRT with an absolute difference of minus 15.5%.
Takeaway 3, interpretation. The KRT reduction is likely a mix of physiological improvement and protocol behavior based on pH targets.
But avoiding invasive lines and subsequent infections is a tangible, patient-centered win.
Absolutely. So what is the future research question? Who benefits beyond just KRT avoidance?
Is there a specific phenotype of acidosis, like pure non-anion gap versus lactic acidosis, where this matters more?
We need a weighted analysis to account for bias in future observational sets to really tease that out.
So outcome drug or dialysis timing drug?
Definitely a timing drug. What were your triggers?
Correcting pH feels good. Show me patient benefit.
Well, keeping the catheter out is a benefit.
That's true. Thank you all for joining us on this deep dive. See you next time.
Thank you for spending your time with Prism Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.